안녕하세요. 반갑습니다. Hello and welcome to this month's SNOMED CT research webinar. I'm Susie Roy, Customer Relations Manager for the Americas and Research Engagement Lead here at SNOMED International. Just a couple of housekeeping items before we begin. You'll notice that everyone is currently muted. If you have any questions as we go along, please enter your questions into the Q&A box. And when we get to the Q&A portion, I'll be sure to call on you first. Just as a reminder, this webinar is being recorded and both the video and the slide deck will be available to watch and look at later this week. I'd like to encourage you all to go ahead and save the date, Wednesday, September 16th, for our next SNOMED CT research webinar featuring Dr. Hugo van Mens of Amsterdam University Medical Center. Dr. Van Mens specializes in informatics research on patient access to medical records and semantic interoperability. In parallel to our SNOMED research webinars, we also have a SNOMED CT clinical web series. These two monthly web series are available free to join live or watch a recording. More information on either one of these webinars can be found on our SNOMED CT web series webpage. And if you're interested in presenting at either the research or the clinical webinar, please contact me because we are looking for volunteers for our upcoming sessions. And one final note on our research engagement. To stay informed, you can either watch that SNOMED web series webpage, or if you'd like more of a push notification, you can sign up for our research reference group. And this is where I post information about these webinars as well as upcoming research related news. In order to join, all you have to do is just email me, sro@snomed.org. And one last bit of information before I hand this over to our presenter for the day. I wanted to do a plug for our annual SNOMED CT Expo. This year, due to the obvious global health situation, our annual October SNOMED CT business meeting and expo will all be virtual. You can go to snomedexpo.org and register for the expo free of charge this year. The expo features researchers, clinicians, SNOMED CT research national release centers, vendors, and many other SNOMED CT experts. Presentations during the expo usually include informatics research, clinical research, various aspects like healthcare data, health data analytics, health IT, and systems implementations, as well as many other experiences utilizing SNOMED CT terminology data. This year, even our educational workshops and tutorials will be broadcast. So if you are keen in learning more about SNOMED CT, this is actually going to be an excellent opportunity because, again, it's all free of charge this year. So again, snomedexpo.org to get more information, or if you'd like, you can also email me. Again, that's sro@snomed.org, and I can point you to where to register as well as any other questions that you have. Okay. So enough of my speaking because I know you've actually all come here to listen to our presenter. So while she needs no introduction, I have the absolute honor in introducing Dr. Hyeoun-Ae Park. Professor Park is Emeritus Dean and a professor at the College of Nursing and a researcher at the Systems Biomedical Informatics Research Center at Seoul National University. She previously served as president of the International Medical Informatics Association. Dr. Park has a distinguished career in nursing and informatics and throughout has been a staunch champion for the use of standardized terminologies and vocabularies and detailed clinical models in electronic health records. And we're very grateful for all of her efforts in international informatics and standards work. Today, Professor Park will be presenting Mapping Korean Classification of Diseases and Medical Procedure Codes to SNOMED CT. And with that, I will hand the screen over to you, Dr. Park.
Okay, I hope everybody can see my slide.
Yes, perfect.
Thank you, Susie, for that lovely introduction. And good morning and good evening to you depending on where you are in terms of time zone. And it is great honor for me to present what we have done in Korea, specifically mapping Korean classification of disease and medical procedure code to SNOMED CT. I'll briefly introduce healthcare and health IT initiatives in Korea before I move on to mapping Korean we call KCD and medical procedure code to SNOMED CT. So briefly, healthcare in South Korea. Oh, I'm sorry. I think I hit something. So healthcare system in Korea basically run by the Ministry of Health and Welfare. We have universal health coverage since 1989. And Korean citizens can choose almost any providers freely in Korea. Our healthcare is funded by a single unified insurer called the National Health Insurance Service. In terms of a provider, private sector is very dominant in healthcare service delivery in Korea. Almost 95% of hospitals are privately owned. However, all the hospitals in Korea are designated as providers compulsorily by National Health Insurance Service. So there is no selective contracting. In Korea, Ministry of Health plans and supervises national health insurance. The ministry sets healthcare service cost to benefit management and set review and assessment standard. Under the ministry, we have National Health Insurance Service as insurer, and we pay contributions to National Health Insurance Service. And we have another agency called Health Insurance Review and Assessment Service. Healthcare providers claim reimbursement to Health Insurance Review and Assessment Service Agency, and based on the review of claims, National Health Insurance Service reimburse to healthcare providers. In Korea, total population is covered by national health insurance. Almost 97% of population is covered by national health insurance. The rest, which is mainly low-income household, is covered by medical aid. In terms of health insurance contribution, amount of national health insurance contributions are calculated based on your income, property, vehicle ownership, age, and gender. Most of us belonging to employee insured pay about 6.5% of our salary as a monthly contribution. And half of the contributions is paid by employer or government. When we use healthcare system in Korea, we pay about 20% of inpatient care out of our pocket, and about 30% of primary care, such as clinics and pharmacy. But if we use advanced tertiary hospitals, we pay up to 60%. In terms of cost and quality, it is very affordable, and the quality is very good. Our healthcare cost is about 8% of our GDP, which is half of the US. And life expectancy at birth is about 82 years, which is 4 years longer than that of the US. So I guess the cost is very affordable and quality is very good. Now I would like to move on health IT initiative in Korea. I would like to highlight 3 initiatives today: Health Information Exchange, EMR Certification, and data-centered hospitals. Health information system adoption rate in Korea is very high. As you can see, most of hospitals have computerized physician order entry system. And across the hospitals, we have about 92% of hospitals have some form of EMRs. And in terms of PACS, except clinics, most of hospitals have a PACS system implemented. However, health information exchange rate is very low. Only 33% of tertiary hospitals say that they are exchanging health information using EMRs. It is very rare for general hospitals and clinics exchange health information using EMR. This is due to lack of national policy and strategy on interoperability. According to a survey conducted by Korean Health Industry Development Institute, hospitals rarely use global terminology standards such as SNOMED CT, LOINC, etc. What they use is a Korean standard classification of disease, National Health Insurance Reimbursement Claim Code for lab, procedures, and drugs for many health insurance reimbursement claims. Very few tertiary hospitals reply that they use global terminologies. In terms of interoperability, health information exchange is the most important initiative in Korea. It was introduced in 2016. It is run by Social Security Information Service. So for patient who has a given consent to transfer his or her personal information to and from a medical institution, medical record of that patient can be transmitted electronically so that the doctor can refer to the record when treating the patient. By this initiative, we hope to achieve continuity of care through health information exchange initiative. So the basically concept of HIE initiative is to exchange health information anytime, anywhere between participating medical institutions. In terms of system configuration, there are regional-based document repositories where registry, master patient index, agreement, withdrawal management, exchange documentation management, imaging information storage is being performed. And there are regional hospitals and the cooperating hospitals referring and returning patient back and forth. And patient agree or withdraw from HIE, and patient can query referral and the returning history of his or hers. Through HIE, services such as patient referral and returning, care record summary exchange, medical image information exchange, and the emergency patient referral support are provided. These are the standard the government asking to use for health information exchange. That doesn't mean that everybody is using this standard, but this is what the government is asking. So as of 2019 December, there are 13 regional-based document repositories were set up, 33 regional-based hospitals, and over 4,000 cooperating hospitals are participating in the health information exchange initiatives. Now, second health information initiative is EMR Certification. It was introduced last year. It is run by Health Information Service. With EMR certification, we would like to have a secure, interoperable health information system which can provide high quality care to support patient safety and the continuity of care. With the EMR certification, we can check whether hospitals adopt national standard or not. There are two types of EMR certification, namely certification of a product, which certifies the EMR developed by the vendor or healthcare institution meets the certification criteria. Second one is certification of use, which certifies that healthcare providers or healthcare institutions are using certified EMR under certification product. They're using it without modification or not. So who are the applicants? Vendors can apply for certification of a product, and the healthcare providers who built in-house EMR can apply both certification of product and certification of use. There are 3 levels of certification depending on the size and the function of the medical institution where the EMR system is implemented. First level is belonging to EMR system for clinics without any bed. Level 2, EMR system for hospitals with less than 300 beds. And the level 3, for hospitals with more than 300 beds. Hospitals with less than 300 beds can apply for level 3, but hospitals with more than 300 beds cannot apply for level 2 or below, level below. This is the certification criteria. Okay. So there are 3 domains: functional, interoperability, and privacy and security. And under each domain, there are items or criteria which are mandatory or optional. Okay, so for functional domain, depending on the level, the mandatory items increase. Under interoperability, every criteria is optional because those hospitals joined health information exchange. We only evaluate those hospitals, evaluate interoperability domain for those hospitals participating HIE initiatives. But privacy and security, every criteria is mandatory. Standard for EMR certification. This is really what we hope to achieve in the long term. So it is not like a standard currently we are imposing it. It's a long-term goal that we would like to implement this standard in the EMR. Since 2019, 8 vendors received product certification. 32 hospitals received use certification. Now I would like to move on to a new initiative called Data-Driven Hospital. This initiative was introduced with the background that clinical data, such as symptoms, tests and medical images, generated during the patient care process is essential for medical technology development, such as new drugs, medical devices, and artificial intelligence. According to revised Personal Information Protection Act, which was passed early this year, it is possible for Korean hospitals or anyone to use healthcare data for scientific research after pseudonymization in Korea. So the basis for safe use was established. after the revised Personal Information Protection Act was passed. Now, there are purposes of data-driven hospitals. We would like to support or promote clinical database research in the hospitals for development of new medical technologies. And we also would like to promote establishment of sustainable medical research database through these data-driven hospital initiatives. Now, who can participate in data-driven hospital initiatives? Medium to large size hospitals or consortium of hospitals with more than 1 million cumulative patient and research capabilities. But if a consortium of hospitals participate in this initiative, they must have contract for joint use of computing facilities or consignment of processing under Personal Information Protection Act. So who meets this requirement can participate in data-driven hospital initiative. The Ministry of Health asked participating hospital in this initiative to cooperate with government project. For example, Artificial Intelligence New Drug Development Support Center, a National Cancer Data Warehouse project, and also clinical data. If there is any project using clinical data for research and development, and they would like to have these hospitals in participating this initiative to cooperate this project. These are the selection criteria for data-driven hospital initiatives. Depending on how much data the hospital have and what kind of governance they have, and ethics, human rights, online, information security, standardization, and any scenario for research use, if they are going to provide a matching fund, and depending on budget plan. And so these are the criteria. Depending on this criteria, 5 consortiums of hospitals were selected in late July. So these consortiums are really picking up the speed for all these initiatives. Now I would like to present mapping Korean classification of disease and the medical procedure code to SNOMED CT. And this mapping was conducted as part of development and dissemination of a standard for EMR certification. And what we have included is a Korean classification disease and reimbursement claims code for treatment and surgery, medication, and laboratory tests in this mapping. The reason why we did this mapping is that the ministry decided that at least the public sector can map existing code and terminology and classification to SNOMED CT. Rather than doing local code to SNOMED CT. And we thought that it's up to private sector to map local code to SNOMED CT. So that's why we conducted this project. Now I would like to briefly introduce KCD-7, Korean Standard Classification of Disease. It is a Korean version of ICD-10. It was published in 2016. It incorporated traditional Korean medicine diagnosis system into KCD-7, and it also reorganized the subtype classification for the most frequent disease in Korea. also incorporated classifiable rare disease. So in total, there are 14,581 diagnosis codes in KCD 7. Now I'd like to briefly introduce the Reimbursement Claims Code for medical services. In Korea, most claims are submitted electronically, mainly using Electronic Data Interchange system, we call it EDI. There are over 9,000 items of medical services covering treatment and surgical procedures, tests, long-term care, medical images, basic treatments, dental services, hospice care, all the medical services you can imagine. And the national standard called EDI code is assigned to each medical services. So in Korea, we call the reimbursement claim code just the EDI code. That's our name for reimbursement claims code for medical services. So basically, EDI code is the basic structure for reimbursement claims of medical services in Korea. So this is a distribution of EDI, medical services code. As you can see, there are like over 2,500 codes for treatment and surgery, and down bottom there are over 2,000 codes for tests, and left side there are about 1,300 codes for long-term care. You know, so this is shows the distribution of EDI code, and almost 95% of these services are covered by National Health Insurance. About 5% are not covered by National Health Insurance. So specifically for this mapping, source materials are about 14,000 KCD-7 diagnosis code, over 22,000 medication code covered by National Health Insurance, over 2,500 medical surgical procedure code, and about 4,000 laboratory test code covered by National Health Insurance. So this is just a part of EDI code that I showed you just before. This is the mapping process. So basically, we extracted source term, and unfortunately, there are a lot of EDI code without English term. For example, all the medication terms, there are no English names for the medication. So we have to translate source term. Then we analyze the source term, dissect depending on the elements or parts or attribute value sets. And then we identify the mapping rules. In order to identify mapping rules, we did the manual mapping, okay? And then using the mapping rule we identified through manual mapping, we did automatic mapping. And if we couldn't do, if the machine cannot map, then we did manual mapping. And we also validated automatic mapping manually. And we classify the mapping result. And then there is a process validation. We did internal cross-validation, and we also asked external expert to validate what we did. And then we published the map between source terms and the SNOMED CT. And during this mapping, we used existing ICD-10 and SNOMED CT map, LOINC and SNOMED CT map, ICD-9 and SNOMED CT map. Now, I would like to move on to mapping KCD-7 to SNOMED CT. The mapping materials are, the source is of over 14,000 diagnoses, we excluded 179 Korean traditional medicine diagnosis, okay? And the target is clinical finding, event, situation, personal top-level hierarchies of SNOMED CT. We did use Argentinian edition because it has a lot more concept and terms than SNOMED CT International Edition. As I mentioned already, we use existing ICD-10 and SNOMED CT map. So if you look at the flow on the left side, we first check if codes and the names of KCD7 are same as those of ICD-10. If so, we check if a map between ICD-10 and SNOMED CT available. If it's available, we use those maps. If it is not available, then we mapped. So we mapped KCD7 with the no ICD-10 mapping available and the SNOMED CT map. And of course, we mapped the remaining, on the left side, there is a 46 unique KCD7. So we did map that. Now, these are the examples of mapping rules we identified through manual mapping. So in order to improve mapping rate, we removed following symbols and words from the KCD7 English name. For example, we removed the parentheses and word within the parentheses, and we removed the comma and hyphen and word with, without, and unspecified, other, complications, and things like that. And also we changed plural noun to singular noun. And we also changed the malignant neoplasm to malignant tumor. So these are just a few examples that we extracted. Mapping rule we extracted during manual mapping. And this is the example of KCD7 diagnosis map to event top level hierarchy. I have a Korean name, I have an also English name. And this diagnosis map to event concept. And this is an example of KCD7 diagnosis map to situation, top level hierarchy. So family history of malignant neoplasm map to family history of cancer. Under situation, top level hierarchy. Another example, KCD7 diagnosis map to person top level hierarchy. KCD7 code was donors of organs and tissues. So since there are two concepts within this KCD term, KCD diagnosis, we map to two SNOMED CT concept, organ donor and tissue donor. We classified mapping types based on these three criteria. First, does KCD7 map to pre or post coordinated expression? Second, KCD map to how many core concepts, not counting number of attribute and value sets, so like how many core concepts were mapped. Third, is KCD7 equivalent or broader than the SNOMED CT concept? So these are the three criteria. And this is mapping result of KCD7 to SNOMED CT. Most of KCD7 mapped to SNOMED CT. So over 99% were mapped. And there are some unique Korean concept did not map. So if KCD7 diagnosis map to SNOMED CT narrowly, then we decided classify it as not mapped. So that's what it is here. This is the Excel file we presented. So if you look at here, we have columns for source term, KCD code, KCD Korean, KCD English, and then ICD code, ICD, mapping type. If diagnosis map to pre-coordinate concept, we have these columns to express that. And if it is mapped to post-coordinated expression, we have core concept and attribute and value sets. So map to more than one attribute and value set, there will be more than one record. So there will be more lines. And then the last column, we have SNOMED CT expression. Okay, so this is the table we provided. Now move on to mapping treatment and surgery code to SNOMED CT. Mapping materials source is over 2,500 medical and surgical procedure code. We excluded dental interventions and surgeries. And target is a procedure top-level hierarchy of SNOMED CT. Now, I did not include common mapping method that we use throughout whole mapping. I just included here a specific mapping method for procedure. Okay, so we use existing ICD-9-CM and SNOMED CT map if available. We analyze the procedure with the 10 attributes. Okay, so these are the 10 attributes we use to when we analyze the procedure, action, procedure, site, associated morphology, and so on. We identified mapping rules by mapping over 800 codes manually, using the relationships of 10 attributes I mentioned before. These are the examples of mapping rules we identified. So for mapping procedure code to SNOMED, we removed the symbols and words, very similar to what we did when we mapped the diagnosis to SNOMED CT, and we dissected complex surgical procedures at the concept levels. That means if a term has more than one concept, that we dissected into more than one concept. And we use the synonyms. Of course, there are English names available already, but if that English name doesn't work for mapping, then we try to use different synonyms for mapping. So these are the examples. And we mapped procedure with the attribute to post-coordinated expression. So this is an example of mapping procedure with the 3 attributes to post-coordinated expression. So here, 3 attributes are procedure, methods, and the surgical approach. And so we mapped procedure with these parts to post-coordinated expression. So this is the expression of post-coordination. Now we classified mapping type, very similar, based on 3 criteria, so I'm not gonna mention. But only difference is that here we have a partially mapped. If, for example, one attribute mapped exactly, but another attribute mapped too broadly, then we classified those as a partially mapped. So that's why we have a partially mapped classification here. And this is the summary, a mapping result of a treatment and surgery code. As you can see, 100% of treatment and surgery code were mapped to SNOMED CT because we use a lot of post-coordination. So that's why we were able to map all of them. And this is the Excel file again, that how we presented mapping between procedure code and SNOMED CT. We have a source term right here, code, Korean name, English name, and ICD-9-CM, because we use the ICD-9-CM map to SNOMED, mapping type, and then SNOMED CT pre-coordination and post-coordination, and then again, expression. Now I would like to move on to medication code mapping to SNOMED CT. This was the most difficult mapping that we did. The source were over 22,000 medication code and names covered by National Health Insurance. The reason why this was most difficult is that there were no English names. That's why we had to translate all the medication names in English. The targets are, we have a few top-level hierarchies for this: pharmaceutical, biological product, substance, organism, and physical object top-level hierarchies. For medication, we analyze medication code into 10 parts so that we can understand what it is. So the 10 parts include substance, dose, unit, dose per dosage form, unit for dose, and etc. We identified mapping rules from manual mapping of 600 medication codes, and we try to map parts, sets of parts or combination of parts to different top-level hierarchies, and we invited pharmacists to review the map we did. So this is the order of mapping medication to SNOMED CT, depending on how many parts we used for mapping. I'm going to explain in more detail in the next slide. So here, for example, okay, except the first one. Okay, first one, if the dose is less than 1, then we converted the unit so that we can map SNOMED CT easily. Now, these are the rules that I was going to explain in the previous slide. If we were able to combine substance, dose, unit for dose, dosage form, and route for administration, we map these medication to clinical drug branch of the pharmaceutical and biological product top-level hierarchy. If we were able to combine substance and route of administration, we added some words and then map to medicinal product form branch of pharmaceutical, biological product top-level hierarchy. If we have only substance, we tried, we added only product and then map to medicinal product branch of pharmaceutical, biological product top level. And if we are not able to map to that branch, then we went to substance, organism, or physical object top level hierarchies. Of course, these are, will be classified as broadly mapped. How come it's not moving? Okay. This is an example mapping medication to clinical drugs. So here we have, we extracted 5 parts, okay, of medication, and then combine them and map to clinical drug branch. Okay, this is the example of that. And here is another example. Combine the substance and route of administration. And then we map the medication with these 2 parts to medicinal product form. Another example, in this case, we have only, we were able to map only substance. So medication with a substance to medicinal product range. And another map to substance, and we classify the mapping types based on level of correspondence and which top level hierarchy or branch we use. So this is the mapping result of medication code. Okay. About 50% of medication were exactly mapped to pharmaceutical biological product. The branch was a clinical drug. Rest of 50% were broadly mapped. Okay, mapped to medicinal product form, medicinal product, substance, organism, or physical object. And there were some medications, very typical Korean traditional medication were not mapped to SNOMED CT. This is the table that how we presented the map of medication code to SNOMED CT. So here we have a source term, standard code, product code, Korean name, English name, company name, sorry, there is Korean, drug formulation, route of administration. And then we also have ATC code and the mapping type and SNOMED pre-coordination, and then the expression. And this is just the unit, okay? Now the last part, mapping lab test to SNOMED CT. Source were about 4,000 lab test code covered by National Health Insurance, and target was a procedure top level hierarchy. So for this mapping, we used existing LOINC and SNOMED CT map. We analyzed laboratory tests into 6 parts in the LOINC template. If you are familiar with the LOINC template, there are component, property, time, system, scale, and method. These are the 6 parts of LOINC. And we identified mapping rules by mapping of 800 laboratory tests manually, okay? Using the relationship of these 6 parts. And mapping was reviewed by laboratory medicine specialists. So this is an example of mapping rules we identified. So map lab test to evaluation procedure branch of the procedure top level hierarchy. And we extract the term within the parentheses. We, by doing manual mapping, we were able to find out this rule. You know, rather than the term before parentheses, what's inside of parentheses is a better term to map to SNOMED. And most of terms did not have measurement of a test, and you know, those are words. So we added one of the following terms to the extracted English name to improve mapping. And we use the relationship of 6 parts of LOINC template to improve mapping. So this is an example of mapping lab test with the component, system, and scale parts, okay? Another example with the component and the system parts. Then another example, component, system, and the scale parts. So we combined these 3 parts, then map to SNOMED CT. So this example, we did map to post-coordinated expression. So you see this syntactic of post-coordinated expression here. And we classified mapping types very similarly. This is the result of mapping of laboratory test. As you can see down bottom, there are over 400 tests were not mapped to SNOMED CT. These are mainly genetic molecular level tests, which were not modeled in SNOMED CT yet. So we were not able to map this genetic test to SNOMED CT. This is the presentation, the map, okay? And here we have a source, term, and the link, mapping type, and SNOMED CT pre-coordination, post-coordination, and the expression. And for those 411 laboratory tests were not mapped to SNOMED CT, we provided a link, a name with a 6 component. So at least we provided a mapping to link for those 411 labs did not map to SNOMED CT. Now, where are we going to use this mapping result? And hopefully, these mappings will be used for national HIS initiatives such as Health Information Exchange, EMR Certification, and data-driven hospitals. And we hope to be used for integration of data from multiple heterogeneous sources and point-of-care clinical decision support, and the statistical information for epidemiology and the reports and the surveillance throughout the Korea. And this is the future plans. We are going to join SNOMED International. I think almost done in terms of application process. So we need to get ready as a SNOMED international member country. So we need to get ready for distribution of SNOMED CT. We need to train and educate people, and we need to develop tools. And we are going to map remaining items of medical services, such as long-term care, medical images, basic treatment, etc. And we would like to develop reference set for a specific disease or specific report or specific surveillance. And as part of this project, we are going to develop a nationwide interoperability roadmap soon. I think this is my last slide.
Thank you, Professor Park. That was absolutely awesome. That was so informative. Yes, I learned a lot, and I'm sure others did too. So go ahead and you can put your questions in the Q&A box. If you would like to ask your question verbally, you can raise your hand and I can unmute you. I am going to be, I'm going to actually jump the queue and ask you a question myself, Dr. Park, because I'm actually kind of curious. In the first part, you talked a little bit about the certification of EMHRs or EMRs. I was wondering, is there a mandate or a timeline for when vendors must achieve a particular level? And other than obviously with interoperability goals and everything, is there any sort of benefit to the vendors for achieving these various certification levels?
That's a very good question. Okay, so as I mentioned, that this was introduced last year. So this is we are in an early stage.
Okay.
So the ministry is developing roadmap for, like when we would like to have all the vendors receive the certification, things like that, and what will be the incentives for vendors or hospitals certified. So this is really a planning stage. So we haven't set anything yet, but those hospitals and vendors are certified. They were certified as part of demonstration, phase. When we developed the certification criteria, when we developed the, like rules and things like that, policies, and those hospitals or those vendors were certified. So everything will begin this year.
Okay. That'll be really excellent to watch. And yeah, from the SNOMED International side, we are excited to watch this as well. So there are a number of questions coming in. So
yes.
okay,
I have.
Oh, go ahead.
Okay, I have several questions. First one comes from Jung Ji-hee.
Yep.
She is asking if my presentation will be available. Yes. How can I distribute this presentation if anybody wants?
Yeah, so Professor Park will, and I will coordinate this, and I'll get your slides, Professor Park, and I will email all of our registered attendees probably later this week, because we'll also get the recording up on YouTube. And so I'll email everyone a link to the YouTube video and a link to the slides, which will be posted on the SNOMED CT research web series page. And so that should be available hopefully by the end of the week. If not at the end of this week, then definitely early next week. So everyone will have a link to all of that.
Okay. And the second question is, among 20,000 medicines, are they all brand name? Yes, they're brand name in Korean. Okay. And next one is, what was the most difficult part of mapping? I think most difficult part was that to extract the meaning of term, a semantic. Okay, I think extracting semantics of the term was the most difficult part. And then next one is, are the certified EMR system able to support storing and transmitting SNOMED post-coordinate expression? No, not yet. As I told you, there are standards that we would like to introduce for EMR certification, but that's a long-term goal. So that's why we are doing this mapping project. So once we finish mapping so-called EDI code to SNOMED CT, then I think we'll be able to do this. So it's going to be, it's going to take a few years. Okay, now.
We have two from Alejandra.
Okay. Okay, when coming to pharmaceutical product, do you have special options for the same active principle? Several pharmaceutical companies are selling several names for, oh yeah, okay. So we don't care what they call it. We really, again, we look into semantics. Okay, so what are the substances? What is the dose? What is the route of medication? You know, so the brand name themselves doesn't matter much. Okay, and just one denomination for each entity. I don't quite understand what.
It looks like Alejandra was asking basically, let's see, do you have several options for the active principle, or just one domination for each entity? So I think you answered that. Alejandra, I'm gonna unmute you so you can clarify here. All right, Alejandra, you're unmuted.
Okay.
Yes, that's because we are in Latin America. We have several trademarks for the same principle, same active principle. And we have problems because of that, because we have the innovative medicine plus 7 other copies. We don't respect patents so much. And that's a problem for these mappings.
Can we talk after this session in more detail. Okay. Okay. Now,
Alejandra and Dr. Park, I know both of you, so I will do a virtual introduction between the two of you.
Sure.
Yeah.
Were any traditional Korean herbal medicine represented in SNOMED as a part of this work? No, we did not include. Oh, no. Okay, for medication, yes. No, we were not able to map herbal medicine to SNOMED CT. Okay, so how many people doing this excellent mapping works? I think 7 or 8 of our research assistant did this mapping, excellent mapping. Okay. Does any hospital in Korea import the SNOMED CT? Oh, what does that mean, import SNOMED CT?
I think this person is. I think this person is asking if any hospital system is currently utilizing SNOMED CT within systems.
Yes, there are a few hospitals. For example, Seoul National University Bundang Hospital. They're using a SNOMED CT quite a lot because they export their EMR system to other countries. So they have to use the SNOMED CT in their EMR system. Okay. Is the mapped data table public available? Yes, it is publicly available within Korea for sure, but I'm not sure if you will be able to see because a lot of README files are written in Korean, you know, so. Okay, I think that's it.
Yep, I'm going to share my screen for just a minute.
Okay.
Thank you. 감사합니다, Professor Park. And 감사합니다 to all of you today. Thank you very much. That was excellent questions. That was an absolutely excellent presentation. We got to learn all about the South Korean insurance system, as well as the health system, as well as current e-health initiatives, and this was just absolutely extraordinary, all of the work that you and your research has done over the many years, Dr. Park. So this was so cool. So I know that there were a couple more questions coming in. So my information is here, sro@snomed.org. Go ahead and email me. And like I said, the slides and the recording will be made available afterwards. And we also have a research reference group where people can message each other, so we can actually start to utilize that for additional research discussions such as what's going on here. So thank you very much, and I hope you all have a wonderful week. Annyeong, goodbye.
Goodbye, thank you, bye-bye.